be a lot of pharmacology and a lot of med math, and not knowing what to study. And I'll be honest, anything in the chapters that we went over is what you should be studying. I can't tell you what's going to be on a test. I can tell you what's going to be on my test, but that's not going to be the same as what's on a test that you take for the master registry. So I can't, teach you the streets versus the textbook. How we have to do it is by the textbook, and then you kind of learn this, how to be a paramedic on the streets with your service. As far as me giving you like tips and stuff like that, sure, absolutely, I will. Things that work for me as a paramedic, but as far as teaching, we just have to stick with the curriculum. So as far as chapters we've covered, 13, 14, and 15 are going to be the main chapters. I'm not saying you have to read the whole chapter, just skim over it, look over some of the highlights. And some of the handouts that I've actually posted on D2L help you follow along a little bit, and it might, assist you. One of the other things that I posted on D2L is, if you looked on there, I now have a spot for extra credit. I'm big about extra credit, because you could answer a couple questions wrong on tests, and our grading scale kind of sucks, so it kind of hurts you with points wise. So how that's going to work is tonight we're going to go through some of that extra credit stuff, so that way you guys are able to print it off, do it after we go through it tonight, and turn it in, and I can give you guys some extra points for that, add it onto your grade. So the first order of business that we're going to go through is the list of drug cards that I posted on D2L for you guys. I'm going to share my screen here in a second, pull up that list itself, and we're going to talk about each medication, what it's used for. I'm not going to mention dosage or anything like that, just how it reacts, or how it acts on the body, and what its classification is. I can't, I guess, give you every single drug that you're ever going to give as a paramedic. That falls to your service, that falls to your protocols, and I can't go real in depth with them, because that's what part of paramedic school is looking at your drug cards and be able to learn them on your own. So before we do that, are there any questions about anything? And your midterm will be next week. I've gotten emails. It is open book. You can use your book for it. I'll be honest with you. Your midterm is mainly comprised of questions from the exams you've already taken. So it should be fairly simple. A lot of the same questions you'll see, if not most of them. So just to give you guys a heads up, so that way it helps with your points as well. Any questions about anything before we kind of get going on our drugs? And then at one point in here, after I go over drug calcs with you guys, after we cover medications, I'll break you guys up into groups. When I do that, I'll have you work on a worksheet in your groups. You'll be in 4 different groups. You can pull the worksheet up on D2L, and in your small little groups, you'll have to talk about it. And then when we come back as one big class, I'll kind of ask you what the answer was for that and how you come up with it. I'm gonna get my screen shared here. All right, are you guys able to see the drug list?
Yes.
Okay, perfect. All right, first drug, and if I call on some random people, just because I want to hear if you've maybe done your drug card for that yet. And remember, I need to see some proof of your drug cards next week. Whether you bring in the skills lab, whether you send me an email of a picture of them, I don't care. I just need to see proof that you're working on them so I can give you a grade for those. First medication that we're going to cover is adenosine. Can anybody tell me what they think adenosine is used for?
SVT.
SVT, okay. SVT is a abnormally fast heart rate, generally caused by some sort of electrical issue in the heart, maybe a medication, maybe caffeine, maybe exercise, a whole bunch of things that can cause SVT. SVT is generally a heart rate above 150, and when we get into cardiology, I'll explain a little bit more as to what SVT is broken down into. But adenosine treats SVT. How it does that is it kind of suppresses an electrical impulse within our heart. It is an antiarrhythmic that essentially slows our heart rate down. When we give adenosine, it has to be given very, very rapidly. It's got a half-life of like 3 seconds, if I remember right. And the closest to the heart you can get an IV to push it, the better it's going to be for the patient. With the adenosine, you will also see the patient flatline for about 4 or 5 seconds. First time I gave adenosine, I was never taught that you'd see a flat line. You'd see the patient go into asystole. For the first time I ever gave adenosine, I was kind of freaked out because I saw that flat line on the monitor, and then they came back to a sinus rhythm. But yeah, we use adenosine to treat SVT, a rapid heart rate, and essentially it just kind of restarts the heart because the heart is our only organ that really runs off of or creates its own electrical impulse. So we're essentially stopping the electrical impulse and hoping that it kicks up on its own through automaticity. I don't expect some of those words to mean anything to you until we get into cardiology, but yeah, it's antiarrhythmic, used to treat SVT. Does anybody know the dose of adenosine? There's actually 2 doses, a 2-part dose.
6 and 12.
6 and 12. First dose is 6 milligrams. If it fails to work at that point, you can administer 12 milligrams. Sure, absolutely. Good job. All right, albuterol, fairly simple one. We can give this as EMTs. What do we think the classification is about albuterol?
Bronchodilator.
Okay, bronchodilator. So when we say bronchodilator, remember there's different receptor sites that we hit in the body. We have alpha, beta 1, and beta 2. Which one is dealing with bronchodilation?
Beta 2.
Beta 2, absolutely. Used to treat, COPD, asthma. It really just opens up the lungs so that we can get a good exchange of carbon dioxide and oxygen. A lot of times, if people listen to breath sounds of somebody with COPD and they don't really hear a whole lot of air movement, it might be because there's a lot of dead space. And so a lot of times we'll give albuterol to try and open them up a little bit, and possibly followed up with CPAP to try to force that air down into their lungs. So classification, bronchodilator. All right, amiodarone is the next one. What's amiodarone used for? What kind of medication is it?
Antidysrhythmic.
Okay. So does anybody know anybody that takes amiodarone or like has a relative that might take it by chance? It's not that commonly prescribed, but generally this is going to be for patients that we see in like stable ventricular tachycardia. Patients that have stable VTach generally will take amiodarone to convert them to a sinus rhythm at home. Now we can also give amiodarone for patients that are in stable VTach to try to convert them to a sinus rhythm. VTach is a cardiac arrest rhythm too, so if left untreated, it can lead to cardiac arrest. But it can also be used in cardiac arrest. So there's 2 different dosages. In cardiac arrest, our first dose of it is 300 milligrams. And then our second dose would be 150 milligrams. As to where if it's a patient stable in VTach, we would generally give 150 milligrams over like 10 minutes in a drip. Or you could sit there and push it slowly if you wanted to. It doesn't matter as long as it's being done over a little bit of period of time. It can't be given rapidly, otherwise you'll send your patient into cardiac arrest. So as far as classification, antidysrhythmic, antiarrhythmic, tomato, it's going to be able to treat that irregular, fast, wide heartbeat. All right, aspirin. Somebody who hasn't answered yet.
It's an antiplatelet.
Okay, go a little bit further into what do you mean by that?
It breaks them up.
So it doesn't break them up. It's not like a clot buster. What aspirin does is it actually gets your blood cells and prevents a clot from forming. It actually puts this coating around your cells so that they essentially kind of like bounce off each other, so they're slippery. It won't break up a clot, but that's why we give it in patients that are having chest pain. Is because we're assuming that their chest pain is of cardiac origin. And what's happening when somebody's having chest pain in their heart, they generally have a plaque buildup in one of their coronary arteries, which leads to reduced blood flow, which leads to reduced oxygen because we're not carrying as much blood. So our hope is by giving aspirin, that we're preventing any further clotting from happening. If that kind of makes sense. What's our dose of aspirin?
324. Total.
324 81 milligrams per tablet, right?
Correct.
Okay. And if you guys have any questions during this while I'm going, just stop me and you can by all means ask about it. All right, atropine has two different uses. First of all, does anybody know the classification of atropine?
Anticholinergic.
Okay, anticholinergic. So, cholinergic, sorry. Anticholinergic. When we talk about a cholinergic effect, we're actually talking about the heart kind of like slowing down, the body slowing down, having to do with our parasympathetic system. Cholinesterase is actually the hormone that causes that. So if we have a drug that's anti slowing down the heart, what would it probably do then? Instead of slowing the heart down, it would do the opposite.
Speed it up.
So remember, cholinesterase is that hormone that slows the body down, kind of that feed and breathe system, that parasympathetic system, it kind of kicks that in. If I give a drug to counteract that, I'm giving atropine because I don't want the heart to slow down. Atropine is used for patients with bradycardia, generally in the 40s, 50s, that are symptomatic. So might have a little bit low blood pressure, might be feeling a little sick. We're going to treat them with atropine. 1 milligram is our dosage. And how it works is, again, just stopping the break of the heart from kicking in. Now, it can also be given for organophosphate poisoning. Does anybody know our dosage for that?
2 to 5 milligram.
2 to 5 milligrams, absolutely. Something that's pretty neat, and I know that we're waiting to get back the dates from them now. Third semester, we have Texas A&M come up, and they teach a weapons of mass destruction class. In that class, it's a 2-day course you guys can go through that really covers any sort of poisonings, any sort of toxins, any sort of chemical and biological weapons, and how we would treat those patients. And they're very big on atropine. A lot of bigger services, and when I say big services, I'm talking like Tucson Fire Department or like New York Fire Department. Those are bigger services that carry an antidote called 2-PAM. And 2-PAM is actually the reversal for organophosphate poisoning. You also see that in a lot of airports. If there's a potential for organophosphate poisonings, because it's pretty common to get your hand on, they'll have high doses of atropine available that they can administer to patients. So it can be used to speed up the heart and treat organophosphate poisoning. All right, Atrovent. It goes by a different name as well. Does anybody know what that other name is? Other name for Atrovent is ipratropium bromide. Ipratropium bromide is what you would see in a duoneb along with albuterol. So when we give a duoneb, we're talking about giving 2.5 milligrams of albuterol along with 0.5 milligrams of Atrovent. Atrovent is, again, an anticholinergic, so it can cause, that's why we give a duoneb and we'll see a spike in the patient's heart rate, is because it can cause their heart rate to go up a little bit. It is still a bronchodilator, so it has that beta-2 effect, and it also works by drying up secretions. So if you have a patient that has that real thick mucousy phlegm, that's why a lot of times we'll give them a duoneb, is because we want to dry that up and allow them to cough some of that stuff up. So remember, in your duoneb is albuterol and Atrovent. Other name, ipratropium bromide.
What was the dose for Atrovent, you said?
Atrovent generally comes 0.5 milligrams. And that's in your duoneb container. I'm not going to go too much in depth on calcium chloride because, again, it is just a electrolyte, just giving calcium. Maybe it's for a patient that has low calcium levels, and we could look at giving calcium chloride. A lot of times if somebody has a weak heart, they might give calcium because the heart also, just like our bones, relies off calcium to strengthen the contractions. So not too much into it. I don't know any really services that carry calcium chloride anymore. Cardizem. Anybody know what Cardizem is, or anybody service carry Cardizem?
Calcium channel blocker.
calcium channel blocker, okay? Do you know what it's used for?
AFib and A-flutter.
AFib and A-flutter, more specifically AFib with RVR. And what that means is a super fast AFib. It would almost be like an SVT of AFib, 150s, 160s. Our concern with AFib is that they can throw a clot. So that's a lot of times why some services are kind of nervous about giving cardizem, is because by slowing that AFib down, they could cause that patient to throw a clot. But you're absolutely right, it is a calcium channel blocker. And actually, if you look on here, I made a mistake because cardizem is the exact same thing as diltiazem, just a different name for it.
Rudy, what did you say that it was AFib with what?
RVR, so rapid ventricular reaction, or rapid ventricular rate.
Thank you.
And like I said, when we get into cardiology in second semester, that'll make a little more sense. All right, who can tell me about dextrose? Different types of dextrose, different things we carry based off of different demographics of patients. What's one that we're very common with?
D50.
D50. Okay, what's the dose of D50?
It is 25 milligrams.
25 grams.
25 grams.
25 grams at 50 mLs. So it's basically 50% dextrose is what it is. Now, we also can have D25. And a lot of times we'll give D25 to like our pediatric patients that we don't want to spike their blood sugar as quickly. To make D25, all we have to do is take a vial of D50 and cut it in half. So we would draw up half of the D50 and then fill the rest with saline, and that gives us D25. So we're essentially just creating our own medication at that point, or diluting it down.
Question on that, Rudy.
Yeah.
So I'm just curious, our service that I work for, one of them carries D10. They don't even carry any I don't think we carry any D50. What's
So
pros and
D10
cons?
So the reason a lot of people don't carry higher dose of dextrose or getting away from it, and a lot of places are carrying D10, is because say we have a patient that has a blood sugar of 40 and we slam 25 grams of dextrose. What happens to their blood sugar? Like
Spike.
it spikes, right? So we get this massive reading of blood sugar, 200-300s. The problem with that is blood sugar that rises really fast falls really fast as well. That's why we tell those patients after we do that, hey, let's get you a peanut butter sandwich, some sort of complex carb that can be broke down, or a simple carb, or simple sugars, that way their body can start metabolizing that to help keep that sugar up. So a lot of services are starting to carry lower doses of dextrose so they don't get that rapid spike, so they can slowly bring them up, slowly bring their sugar up, instead of that rapid up to 300 and then back down. As to where if you're given like D10 or D25, it slowly brings them up to, the 150s, 200s range, and then might stay there for a little bit longer. And it allows their body to build up glycogen stores when that happens. Our body naturally stores glucose as a reserve. Even when, our unconscious diabetics, they still have a glycogen store that's built up inside the liver. Now, the body doesn't release that unless it is told to, and which I'll get to that here shortly. But yeah, that's the reason some services are even carrying like D10 drips, to be honest, to slowly raise their blood sugar up. If that makes sense. Now, what's a problem? Let's say you start an IV on a patient, you blow the IV, and you start giving dextrose to it. What's our issue with that?
Become necrotic.
It's super necrotic. It's just like, think of a patient that's diabetic that generally has a blood sugar of 500-600 that's not controlled. What starts happening to like their tissue? What starts happening to their legs? They start getting these sores. They start getting these open wounds because that's essentially the body eating itself. Their blood sugar levels are so high. Well, so if we start an IV, blow it without even knowing it, give dextrose, we can actually cause tissue necrosis by giving dextrose. That's where you want to stop what you're doing immediately. Make sure you're notifying the hospital when you get there. Hey, I gave dextrose to that line. it was blown, so that way they know and they can watch for any symptoms of it. All right, our next med, diazepam. Anybody tell me the other name for diazepam?
Valium.
Valium.
Valium. What classification is that?
Benzodiazepine.
Benzodiazepine. So what do we use those for?
Seizures.
Seizures, most commonly. Valium really isn't, I would say, is kind of going by the wayside a little bit. A lot of services aren't carrying it as much because Valium can't be given. It's a very thick medication, so it's a lot harder to give IM or even intranasally for that matter. So and the dose is a lot higher. That's where you see a lot of services starting to carry Ativan or Versed, or choose one, give Ativan or Versed before they give Valium. Valium's like their last resort. But remember, any medication that ends in that PAM or AM is a benzodiazepine generally. And yeah, they suppress any rapid firing of your electrical impulses inside our brain, so that way we can stop seizures. Diltiazem, same thing as cardizem again. It is a calcium channel blocker used for AFib RVR. What about diphenhydramine? What's the other name for diphenhydramine?
Benadryl.
Benadryl. Okay, what classification is Benadryl fall under?
Antihistamine.
Antihistamine. Okay, so when we have an allergic reaction, and I'm talking, a mild allergic reaction, not anaphylaxis or anything like that, our body releases histamine. Histamine is what causes the hives, is what causes the itching, the little blanch spots that we get. So Benadryl is meant to counteract that, to essentially take away the histamine and stop histamine from taking the effect on the body. What are some side effects of Benadryl?
Sleepiness.
Sleepiness. Okay. Yeah, that's if you're gonna give Benadryl to your patient, let them know, hey, you're probably gonna get a little bit tired after I give you this. Just kind of warn them a little bit. Benadryl can also be given for some behavioral issues as well, to calm people down, essentially by making them tired. Has anyone ever heard of a B52 before?
I have.
Okay. A B52 is something it's something that, like the service I work at now, we actually use quite frequently. It's a combination of Haldol, Benadryl, and Ativan. It's, I think it's 50 of Benadryl, 5 of Haldol, and 2 of Ativan, if I remember right. And they just call it a B52. It's for like an antipsychotic medication, essentially, to knock patients down that are having like schizophrenia. All right, dopamine, one we're probably tired of hearing, talking about drips. What is dopamine?
Sympathomimetic.
Sympathomimetic, is that what you said?
Yeah, sorry, I kind of butchered it.
Yeah, it mimics the sympathetic system. So dopamine is also a natural neurotransmitter in our body. It's what makes us happy. Dopamine is what, gives us excitement. Now, a dose for dopamine falls in the 2 to 20 micrograms per kilogram range per minute. Low dose of dopamine, like 2 to 8, can actually cause renal perfusion, lead to renal perfusion. So if I'm telling the kidneys to work overtime, what do you think I'm doing to my blood pressure? Am I raising it or lowering it?
Raising it.
You're going to lower it.
Lower it. If I'm telling my kidneys to work faster than they normally are, I'm asking it to essentially get rid of more fluid than it normally does. So low dose of dopamine can actually cause low blood pressure. That's why low dose dopamine is actually used in dialysis patients. What we use it for is as an antihypotensive. We might use it post cardiac arrest in patients, use it in patients that are in shock, because it has great cardiac effects. It has great ability to stretch cardiac muscles and allow them to squeeze harder. But that's only like the high dose range. That's generally 10 to 20 micrograms per kilogram per minute. If we go that low, there's a chance we can, again, drop the patient's blood pressure. So do the opposite of what we're wanting. All right, epi 1-to-1, epinephrine 1 to 1,000. What do we use it for?
Anaphylaxis.
Anaphylaxis, okay. What else? As paramedics, we can use it for dyspnea or difficulty breathing. We have the patients that, or maybe they're having a severe asthma attack, having severe COPD exacerbation. We can give IM epi. We can even give IV epi to calm them down a little bit, to open their airways up. You got to think, epi 1 to 1,000 works on alpha, beta 1, and beta 2. So it causes vasoconstriction because it's epi. It causes increased heart rate because it's adrenaline, and it opens up your airway because it is a bronchodilator as well. That's why we give it an anaphylaxis, because we want all three of those properties to kick in. Epi 1-to-1 is generally given IM. That's why, does anybody know our adult dose?
.3 to 0.5.
Same as an EpiPen, right? 0.3 to 0.5. All right. So then what is epi 1 to 10,000 then? Different, same medication, different concentration. What do we use that for?
Cardiac arrest.
Cardiac arrest, absolutely. That's being pushed in our patients that are in either shockable or non-shockable rhythms. Any cardiac arrest, we are going to be using epi 1 to 10. Generally comes 1 milligram in 10 mLs. Our little Bristow jets, those little glass vials that we have that fit into a syringe. As to where epi 1-to-1 will either come in a ampule or in a vial itself. A lot of times if they come in the vial, they'll be labeled as adrenaline. All right, what about etomidate? What do we use that for?
It's a hypnotic used to calm people down.
Hypnotic, absolutely. So used for induction mainly. What would we use it for induction for?
Intubation.
Intubation, RSI. Do we know what our dose is of etomidate? Also, amidate is another name for it.
0.3.
0.3 milligrams per kilogram. This is pretty common. Again, it's a hypnotic to kind of put the patient in a trance before we administer a paralytic. Fentanyl, who doesn't know about fentanyl? What's our classification of fentanyl?
Analgesic.
Analgesic or opioid, opioid agonist. Remember, agonist creates a response, antagonist reverses a response. So if I have fentanyl that's an opioid agonist, then Narcan would be my opioid antagonist because it's going to reverse the effects of fentanyl. Again, dose for fentanyl kind of just depends on protocols. It's either 50 to 100. Most protocols now will say 1 microgram per kilogram for our patients. All right, what about glucagon? Does anybody know what does anybody still carry glucagon?
We do in Waukee for some reason.
We do.
Okay. The only reason a lot of places are starting not to carry glucagon is because the cost of it. It's like $350 for 1 dose. How glucagon works is it's actually given IM. It comes in like this little red container. And what it does is, remember how I said your body stores glycogen? This is for patients that maybe we can't get access on, and we need to release those glycogen stores to bring their blood sugar levels back up. We would give glucagon because glucagon will activate those stores and let them know to release. and then hopefully the patient's blood sugar will come up. It does take a little bit longer. It's not like D50 or D25 where it comes up, within 5-6 minutes. This could be 15-20 minutes where you start to see a response.
Rudy, do you generally see diabetics carry that or have that prescribed?
I've only ever seen one, and it was because it was a cancer patient, and they had to pay for it out of their own pocket because for some reason that just dextrose would not bring their blood sugar levels up to where they needed to be. And the problem is you can only give glucagon so often because those glycogen stores have to build back up. So if you give one right after another, you're really doing nothing with the second one because there's nothing to release.
Yeah, I saw that years ago when I was a first responder. It was actually a lady I used to work with. She left work because she couldn't get a hold of her husband, gave us the wrong address. That's the short story. Took us a long time to find her. And she ended up having glucagon. He had glucagon at home and gave that to him, and it saved his life.
Mm-hmm. Yeah. And again, it comes in a little red case, and you generally have to constitute it kind of like Solumedrol, where you got to squeeze them together. Some of them you have to inject saline into it and then pull it back out. That's more common. All right, haloperidol or Haldol. I kind of spoke about that a little bit. Antipsychotic, generally used to treat schizophrenia. You'll see this more in hospital. Some services, maybe if you've got a long transport time, some services do carry Haldol if needed. But again, this is mainly going to be your hospital-based EMS services that are going to carry those. All right, insulin. What is insulin's job in the body?
Facilitate glucose transfer.
Facilitate glucose transfer, absolutely. So diabetics that have really high blood sugars, it isn't the fact that they just have sugar floating around their body. It's the fact that their body can't use that sugar because it doesn't have enough insulin. Insulin is like a bridge that glucose uses to cross to get into the body, into the cells. If that bridge isn't there, glucose can't get into the cells. So insulin acts as that bridge. I mean, it's kind of odd. Everybody thinks that insulin just automatically knocks down blood sugar. No, it works by allowing blood sugar to do its job, to allow glucose to do its job. Think of it as a bridge between glucose and your cells. All right, what about ketamine? What kind of medication? What's our classification for ketamine?
Anesthetic.
Anesthetic, okay. So it can be used for RSI as well. Can be used for pain management. It is technically classified as a dissociative, puts the patient again in a trance-like state. They kind of don't know what's going on. They're kind of out of it. Again, it's great for pain management, especially if you've got somebody maybe with like a broken limb, like I don't know, a long bone, or some sort of spinal break, possibly a spinal fracture. It is great for that because it will literally take away all their pain. Some people kind of still don't approve of it in EMS, but I'll tell you from using it, it is a great drug for patients that are in severe pain. I have yet to use it to intubate somebody, but for pain management, it works pretty well. All right, lactated ringers. Anybody carry lactated ringers, or if your service does? Lactated ringers is another type of fluid. It's kind of like normal saline, except you'll see lactated ringers given more in patients that maybe have a severe infection, that have some sort of sepsis. They might give lactated ringers, and they'll also give it in burn patients as opposed to normal saline. Why would they give lactated ringers over normal saline to a burn patient? What does normal saline contain?
Sodium chloride.
Sodium chloride. Sodium meaning salt. So do we really want to give salt to a burn patient that is already having fluid management issues?
No.
That's why we give lactated ringers. All right, lidocaine. What do we use lidocaine for?
Localized anesthetic and harder.
Localized anesthetic. Okay, and cardiac medication. So an antiarrhythmic. When you guys go through ACLS, lidocaine is an antiarrhythmic that is about the same as amiodarone now. Dose of it is 1.5 milligrams per kilogram for cardiac reasons. And then for maybe like conscious IO placement, we would honestly give lidocaine after we insert our IO to numb up the area before we flow any fluid, because the act of drilling might hurt a little bit, but pushing the fluid through somebody's bone is what causes the most amount of pain. All right, lorazepam. What's the other name for it?
Ativan.
Ativan. Okay, what do we use it for?
Anxiety.
Seizure.
Anxiety and seizures. Generally, those are going to be the most common. Maybe we have to calm somebody down. I'm not talking about sedate them. Just bring them down from a 10, maybe to a 5. And then seizures, absolutely works great for that. What about mag sulfate? Another electrolyte, magnesium. What would we give mag sulfate for?
Eclampsia patients.
Yeah, eclampsia, especially if patients are having, that preeclampsia. They're starting to get like spots when they see their blood pressure's elevated. We could look at giving mag sulfate, or if they're having seizures related to eclampsia, we would look at giving mag sulfate. We can also give mag sulfate for a cardiac rhythm called torsades. And I want you guys to remember that, write it down, because when we go through cardiology, it'll make a little bit of sense. All right, mannitol. Anybody know what mannitol is? Okay, it's a diuretic. Why would we use that then? We can use it if we want to essentially, reduce fluids in the body. Mannitol is most oftenly given for patients with increased intracranial pressure to reduce some of that pressure inside their brain. That's where you'll see mannitol given most often. And a lot of times, flight is going to carry these, and in hospital, I don't know any EMS service that carries mannitol. But the reason I want you guys to know some of these drugs is because you're going to experience them in the hospitals. All right, methylprednisolone. That one. What's the other name for it?
Solumedrol.
Solumedrol. What's our dose for it?
125 milligrams.
125 milligrams. Are we gonna see a response from our patients by giving them solumedrol? And what patients would we give solumedrol to?
Like asthma.
Yeah, breathers. I give solumedrol to any breather patients that I have. 125 milligrams. It's a steroid. We're generally not going to see a response in the small time we're with the patient, but it'll help them in the long run. It'll help reduce inflammation while they're at the hospital, especially if they're going to stay there for a little bit. It'll help reduce some of that inflammation in their lungs. That's why we give solumedrol, not just to treat the patient while we have them, but to further their care, especially when we transfer it. What about metoprolol?
Beta blocker.
Beta blocker. Any medications that end in LOL are a beta blocker. What do we use beta blockers for?
SVTs, atrial fibrillation, A-flutter.
Okay. What is it most oftenly used for? It's most often used for blood pressure control. You'll see a lot of elderly patients prescribed metoprolol because they have high blood pressure. And by giving them a beta blocker, we're hopefully reducing their blood pressure. You got to be careful because you're assessing your patients, and you have a patient that takes metoprolol and you don't know that yet. You ask them, hey, do you have high blood pressure? No. and you find out they have a prescription for metoprolol. Well, I don't have high blood pressure. I did before I started taking that medication. Now my blood pressure is normal. Patients are tricky, so we've got to be careful and really dive into an assessment when we're doing it on them. But anything that ends in an LOL is a beta blocker. What about midazolam?
The
Benzodiazepine.
benzo.
What's the other name for it?
Versed.
Versed. I know this sounds sick. Versed is one of my favorite drugs. What do we use Versed for?
Seizures and anxiety.
Pain
Seizures
management.
and what else?
Pain control.
Pain management.
Pain control, absolutely. So seizures, obviously, it's going to suppress any seizure activity. It can be given IM, IV, intranasally. It's really great for pain management. I had a patient 3 days ago that broke his humerus, and when I say break, I mean it was like broken. And we administered 100 micrograms of fentanyl and 5 of Versed to this patient. He was a pretty big guy. Pain went away automatically. Felt like he didn't even know that his arm was broken. He obviously knew, but his pain was gone pretty quickly. Just be careful. First time I ever gave Versed was for a patient that had broken their leg, and their leg was actually facing the opposite way, it was facing backwards. And so me freaking out as a new paramedic, I draw 200 micrograms of fentanyl, administer it, and then top it off with 5 of Versed. What do you think happened to my patient?
Tried to get up and walk away.
No, they were not going anywhere. What happened was they stopped breathing because I sedated them too much. I snowed them. And it wasn't until I had them on N-Tidal, because anytime I give a medication that could potentially sedate a patient, I put them on N-Tidal because my monitor will start alarming, letting me know if their breathing is having any issues, or if they're having any issues with the respiratory system. And I look up and my monitor says apnea. I look at the patient's chest and their chest isn't rising. Still has a good pulse, but I knew what had happened at that moment is I gave them too much medication and sedated them. I mean, sure, yeah, I took their pain away, but I had to bag them the whole way to the hospital. So just be careful of that, not to overdose our patients. All right, what about morphine?
Pain management.
Okay, what's the classification of it?
Opiate.
Opiate, right? Okay, what would be our reversal agent for that then?
Naloxone.
Naloxone, Narcan, very similar. A lot of places are getting away from carrying morphine. I think morphine is a great drug because it works every time you need it to. General dosage, you'll see anywhere from 1 to 10 milligrams it can be given. Just be careful again, because morphine isn't given very commonly. And if you give too much, you can sedate your patients. All right, naloxone, what's our other name?
Narcan.
Narcan. It's that time of year we get pumpkin spice Narcan, right? What's our dose of Narcan?
0.4.
0.4 to 2 milligrams. Generally, when we give Narcan, what happens with our patients? How do they react?
They start breathing better, unless you give them too much, and then they come to really suddenly.
That happens too much.
You take their high away, they come to, and they're a little agitated.
Okay. How can we try and relieve that agitation?
Pre-oxygenation.
Pre-oxygenation. They're not waking up pissed because you took away their high. They're waking up pissed because they weren't breathing. They were hypoxic. The brain was suffering. I guarantee if you put a overdose patient on N-Tidal, it's going to be sky high. So what some services are now doing is they'll bag their patient down to an acceptable limit, then give the Narcan. So that way their patients don't come up swinging. Just be careful when giving it. Fairly safe drug. I could take it sitting here right now. It's not going to have any reaction on me. Nitroglycerin. What do we use it for?
Chest pain.
the chest pains, okay? How does it work?
Vasodilator.
Vasodilator. So remember what I said with chest pain, we have a plaque buildup in those coronary arteries. Well, if I give nitro, I'm opening that vessel up. I'm not taking away the plaque buildup, but I'm making the walls around it bigger. So allowing more fluid to flow through. It's like taking a 1-inch pipe and making it a 6-inch pipe. I can put a lot more fluid through that 6-inch pipe. That's essentially what we're doing with nitroglycerin, is just trying to restore some blood flow. Which is why in some patients that are having a STEMI or a heart attack, we have to be a little bit careful on if we're giving them nitro or ortho, because what happens if we open the container up and blood pressure's low? Think of like a big sewage drain pipe, and you know just the bottom is covered in water. If I open that pipe up another 10 feet, does the water level change?
Goes down.
Not really. It technically goes down because the pipe's bigger, right? It's the same concept with it's not, we're not changing a fluid, but we're just changing the surrounding pipe that the fluid is in. So we could essentially drop that patient's blood pressure really quickly. That's why we don't give it to somebody unless they have a systolic blood pressure of at least 100, because we're just concerned about tanking them and bottoming them out. All right, nitrous oxide. Who carries nitrous oxide still, and what do we use it for?
It's an analgesic.
Shane, you're an advanced EMT. You can give nitrous oxide. It's an analgesic. How do we give it to the patient?
50% oxygen, 50% nitrous oxide. You administer it through a non-rebreather, and it's self-administered. As soon as they have had enough, they'll automatically kind of stop breathing into it.
Or if they pass out, they drop the mask. Truly. But yeah, we can use it for pain management. It's no different than us going to the dentist and getting nitrous oxide before they do a procedure. Norepinephrine, natural hormone inside the body. It is adrenaline, essentially. When we get an adrenaline dump, it's because we have a massive rush of dopamine and norepinephrine. What would we use norepinephrine for, knowing that it's adrenaline?
Bradycardia.
Do what? Sorry.
Speed up the
Bradycardia.
heart rate.
You could use it for bradycardia, sure, but we would also use it in our patients that are severely shocky, that we just cannot maintain a blood pressure. We can't keep their blood pressure up. They're tanking, maybe septic shock or cardiogenic. We could look at giving norepi. The other name for norepi is Levophed. It's a very potent agent used to increase blood pressure and increase heart contractility.
I have a question about that, Rudy.
Yeah.
What's the major difference, I guess, between norepinephrine and epinephrine?
Norepinephrine is concentrated differently. To be honest, it's meant for IV infusion, not push. It is your big difference. It's just a constant. Imagine just a constant push of Epi 101. That's what Norepi is.
Okay.
Just a drip of it. Like I said, if you see a patient on Levophed, they're a sick patient. Normal saline. What do we use it for? Fluid replacement, right?
Everything.
Everything. We can use normal saline for anything. What I'll tell you is be careful with trauma patients. Have you guys ever heard of permissive hypotension?
Yep.
In trauma patients, we don't want to overload them with fluid because what can happen to blood clots? Think normal saline doesn't have any clotting agent. It doesn't have any fibrin. So you're essentially taking away the clotting agents by thinning the blood. In traumas, they don't need saline, they need blood. We give saline just to maintain a systolic blood pressure of at least 90, and that's it. We don't want to push them over the edge and throw clots because we start giving too much saline and we push the clots out of their system. All right, on Dancitron, what's our other name for it?
Zofran.
Zofran.
Zofran. Okay, what do we use it for?
Nausea.
Okay.
Nausea. Okay. What's our dose?
4 milligrams.
4 milligrams. I love Zofran. I don't know why. Everybody should get Zofran just automatically. It's a great drug. Patients know what it is because you can get it over the counter. It's one of those drugs that, again, we can give it to pretty much anybody. When we start getting into cardiac, we'll talk about why Zofran can be a little bit scary if we're not careful with it. Oral glucose, what is it? Basically jelly in a container. What's our dose of it?
$15 grams.
Okay, how much is 15 grams? Oh, you don't remember this from your EMT days. 15 grams is basically one tube. So if we're gonna give it, we give the whole thing. I'm not gonna cover oxygen unless we need to. Oxytocin. What's oxytocin? What's another name for oxytocin?
Oxycontin.
No. Pitocin.
Idocin?
Pitocin. What is it used for? Mainly used for patients that are experiencing or they want to induce contractions. So it's used for our pregnancy patients. Racemic epinephrine. Epinephrine. Does anybody know what racemic epi is? And does anybody carry it? We can all mix racemic epi. All racemic epi is it's epi 1 to 1000 that you put in a nebulizer and you add saline to it. And it's used, the only real use for it is patients with croup. Those patients, our pediatric patients with that steel barking cough, they'll administer racemic epi to open up their airways. You got to think it's a bronchodilator. That's why they give it that way, to open up their airways to reduce any swelling.
Rudy, have you ever seen it used for anything else? This is a trick question. I saw it used for something else the other day. I was just curious if you have.
I have not.
We had a guy that was having an allergic reaction in the ER. Well, we thought, and the doctor tried it to think it would help, and it helped a little bit, but he ended up getting intubated anyways. But I've never seen it used on anything other besides kids until that day.
Yeah, and that might be a doctor thing. I can't see a reason why we would do that, to be honest. But I mean, sure. I guess it's still epi. The route of administration doesn't make sense, but whatever. Rocuronium. What do we use it for?
Paralytic.
Paralytic. What type of paralytic?
Is it non-depolarizing?
Non-depolarizing, absolutely. So we don't see the fasciculation. We don't see the muscle twitches when we give it. Rocuronium lasts a lot longer than its counterpart, Sux. Sux has a very short half-life, generally 5 to 10 minutes. Sux is a depolarizing, so that's where you'll see the muscle fasciculations, the eyelids twitching, because remember, Sux makes the muscles expend all their energy and then just doesn't allow them to rest and doesn't allow them to re-energize. As to where Rock and Vec don't let the muscles work at all. They just stop the action immediately. Even though the muscles have built up energy, they don't allow them to work. Sodium bicarb. we would use for, you can actually see it used in cardiac arrest. If it's like a prolonged arrest, we would give bicarb to reduce the amount of carbon dioxide, to reduce it. Actually, it's kind of hard to explain without getting into pathophys. Sodium bicarb binds to certain ions and lowers our acidic level if we're giving it for that reason. The same reason we would give for crush injuries. Generally, if somebody has a crush injury, we don't want to just lift the object up right away because there'll be a rush of built up acid into their body, and it'll actually put them into cardiac arrest. So a lot of times they'll give them bicarb prior to knock some of that acid down. You'll also see it given for tricyclic antidepressant overdoses, TCAA overdoses. Succinylcholine, I talked about a little bit, neurotransmitter blocker, paralytic, depolarizing, so you see the muscle fasciculations. What about terbutaline? What is terbutaline? What's the other name for terbutaline?
Breathing.
Breathing. I don't know why I hate terbutaline. I just hate the name. What do we use it for?
Breathing.
Yeah, it's a bronchodilator. It can also be used in pregnancy patients to stop contractions. All right, little pop quiz for you guys. I'm gonna drop some knowledge on you here. If I have a patient that is a severe alcoholic and his blood sugar, maybe let's just use like a homeless person that's been wandering the streets, he's altered, we check up blood sugar, it's 40. Me as a paramedic, I happen to carry 2 different medications and I give them. One of them is D50 and the other one is thiamine. What is thiamine?
It's a vitamin.
Okay, what type of vitamin? Vitamin what?
B1.
Vitamin B. Okay, so why would I give that to a chronic alcoholic? Alcohol can cause lower levels of vitamin B. And that's why like some services will carry vitamin B just for that instance, especially services that might treat a very large poverty or homeless population. They might carry it for that instance just based off the alcoholism. It can have lower vitamin B levels. Toradol, what do we use it for? Some services are actually making a comeback carrying Toradol, but it's mainly carried in hospitals. What is it?
Pain relief.
Okay. What type? When you do your
had it used in the hospital for migraines.
Okay. It's like a big Tylenol. It's like IV Tylenol. You'll see patients that come in because they're in pain in the ER and they give them Toradol and the patients get pissed because they wanted an opioid, not Toradol. Toradol is an NSAID. It's just like a over-the-counter Tylenol, except you give it IV push, high dose. All right, and last but not least, Vecuronium. What do we use it for?
Paralytic for RSI.
Yeah, and it takes a little bit longer, kind of like rock. Has a longer duration of action. It is a non-depolarizing, so it blocks the muscles from vesiculating. And again, for RSI, absolutely. All right, for some of these medications, did going through some of these help out a little bit?
Yeah.
If not, don't lie. The biggest thing that will help you guys is when you can start pushing these medications. I know it's frustrating now because you're learning medications you don't have in your hands, but when you start getting into the ER and field sites and everything in the next, oh God, it could be 3 weeks. You guys will have your hands on a lot of these medications, and I want you to really quiz the preceptors that you have and ask them what you're giving this for and what your dose is. That's how I had to start remembering. I was actually getting my hands on them, drawing them up and pushing them. All right, let's take a 10-minute break. and then we're going to come back and talk about drug calculations a little bit. All right. Remember last time how I said it was kind of hard for me to show you guys med math when I couldn't draw it out? So I specifically requested a computer that has a touchscreen with a stylet that I could draw some of this stuff out for you guys. So I don't want to hear that I've never done anything nice for you when I sacrifice my own computer. All right. So one of the surveys that I'd gotten back wanted to know about formulas. There are really only two formulas that you need to know as far as how to figure out how much of medication to be given. So the first one is if we're taking medication out of a vial. So we'll just label this one. If I could get this to work, great. The Give me a computer doesn't work. Interesting. We'll call this one drawing up meds. All right, you guys able to still hear me though, right?
Yeah.
Okay. So the formula you need to know is desired dose over available dose times available volume. And that gives you how much you need to give. So an example of that is Zofran. Zofran comes in 4 milligrams in 2 mLs. Okay. And you are ordered to give 2 milligrams. So your desired dose is what's ordered. So they want you to give 2. How many do you have total? Well, I have 4 that is available. And then available volume times available volume. My available volume is 2. So times 2 equals, what's 2 divided by 4?
1.
Are you talking
2.
one's the answer? Or
2.
5.
2 divided by 4 is 0.5. So 0.5 times 2 equals 1 ml. Does that one kind of make sense?
Yeah.
And that's the formula that you need to know when you're trying to draw up medications. Desired dose over available dose times available volume. So let me erase that. Does anybody need any clarification on that? Okay, then I'll show you the other formula that you need to know. Okay. This is your other formula. Volume to be infused over time and minutes times the drip set that is ordered. Okay. So an example of that, if I want to infuse 300 milliliters, think of 300 mLs of normal saline. So 300 goes on top. And they want me to do it in 2 hours. So 300 over time and minutes. So 2 hours is 120 minutes times the drip set to be used. Let's say we're using a 10 drop set. So I would do 300 divided by 120. I need to use a calculator for, which is 2.5 times 10 equals 25. So the answer would be 25 GTTS per minute, which means drops per minute. Don't let questions that are asking you confuse you. The questions they're asking confuse you, because they'll put a lot of fluff in some questions, and all you have to do is figure out the medication, the time, and the drip set. If they give you that, you can figure it out. And how they'll sometimes try to confuse you is by saying, okay, you have to administer lidocaine. You're asked to administer 1,000 mLs of lidocaine over 3 hours. So what's 3 hours in minutes? 180 using a 60 drop set times 60. It doesn't matter that it's a medication. They're still asking me to give it over a certain period of time. So 1,000 divided by 180 is 5.5 times 60 equals 333.3. Does that make sense? Those two formulas? It's simple math.
Yeah.
You can use a calculator for it. So that's fluid to be infused and how much medication you drop out of a vial. The one I have a feeling that people are getting confused on is like dopamine. Is anybody still having troubles with that? No. We'll do another one here real quick. Okay, so I'm gonna ask you guys the questions and you tell me what I need to put up on the screen, like what I need to draw. I'm getting used to this still, though. It's fine. All right. You have a 154-pound patient that needs Lasix. The physician orders 40 milligrams IV push. The vial of Lasix comes supplied 100 milligrams and 10 mLs. How many mLs do we need to give that 40? So we do desired dose or available dose times available volume equals
4 milliliters.
Yeah, so 4 mLs. And like I said, they'll try to confuse you and say like that one threw in weight. It's again because they're just trying to throw stuff at you. Just look for the numbers and break it down into the formula. Any questions on that? Okay, good. All right, so what I'm going to do now is anybody logged on to D2L right now?
I think I am.
Okay.
Yes.
Let me stop screen share. So what I want you guys to do is I'm going to put you guys in breakout rooms. I want somebody from each group is going to have to log into D2L, and under extra credit, I have, let's see what it's labeled as. 1 second. It is labeled as extra credit chapter 14. We did numbers 1 and 2 on that worksheet just now. That's what I pulled up that I wrote on there. So somebody from each group is going to have to log on to D2L and read this to the group and tell you what your numbers are. And you guys will have to figure out the drip rate or how much medication we're going to give. So I will try to pop into your groups and tell you what number I want you to do of that worksheet. I've never done breakout rooms before, so we're gonna get through this. But there's 3, 4, 5, and 6. So once I break you guys up, I will pop into each room individually and tell you which number to do. Okay. So just hang tight while I get this set. If I could figure out how to do it.
what I'm getting.
All right, I'm bringing everybody back to the big room.
Okay.
I'm not gonna lie, for never using breakout rooms before, that was pretty cool. And I could just kind of pop in and check on you guys. All right, who was group one? Shane, that was your guys' group. Do you remember who was in your group?
I was too.
I got Spencer, Scott, Nick, Nate, and Shane for room one. So who wants to explain how you guys did this?
So as you pointed out, the wording in question number 4 was a little wonky. But you are instructed to prepare and hang a lidocaine drip of 2 milligrams per minute. The lidocaine is packaged as a 20% solution containing 1 gram per milliliter. You will use a micro drip, 60 drops per milliliter. Administration set at how many drops per minute will you run the IV? Now you corrected us to it comes in a 500 milliliter bag.
Mm-hmm.
So we interpreted that as saying you have 1,000 milligrams per 500 milliliters.
Okay.
And
I'm going to draw this out. I'm going to draw this out while you're saying it. So.
Okay. And that reduces down to 2 milligrams per 1 milliliter. We're going to be giving 2 milligrams a minute. That means we're going to be giving 1 milliliter a minute. That means we're only going to be giving 60 drops per minute.
Okay. So this lidocaine comes 1 gram in 500 mLs, right?
Yeah. That's what
Okay.
I just said.
You are ordered to give 2 milligrams a minute. Well, we've got to change the grams to milligrams. So 1 gram equals 1,000 milligrams in 500 mL still. That equals 1,000 divided by 500 is 2 milligrams per ml. Okay. So now how I do this is I would draw my clock. We're using how many drops at?
60 drop.
Okay, so 60 goes at the top. 30 is half of 60. 15 is half of 30. And 45 is in between 60 and 30. I know my concentration is 2 milligrams. So 2 goes at the top. Half of 2 is 1. Half of 1 is 0.5. 0.5 plus 1 is 1.5. I want to give 2 milligrams a minute, which is equal to 60 drops per minute.
Yep. And that's what we got.
Okay. Did that make sense for anybody watching and listening? Sorry, my drawing's kind of all over the place. Okay, moving on. Good job, guys. Room 2, I have Andrew Graham, Alex Potter, Anna Brady, and Barry. Is it Keen? Is that how you say your last name? Cohen?
Kane, actually, but
Keen. Okay.
not too picky on that.
Okay. All right, let's go through yours. Let me get my screen pulled back up here. Let me erase this. And you guys had question 3, right?
Yep.
Okay. All right, so question 3. There's a couple different things here. So your medication is ordered at 1 microgram per kilogram. Lidocaine package is a 1% solution containing 100 milligrams and 10 mLs. I'm just writing this stuff out and then I'll have you explain to me. So here's how much you have. Patient weighs 198 pounds. All right, so it's asking a couple different things here. So what is the patient's weight in kilograms?
Should be 90 kilograms.
Okay, so 198 divided by 2.2 equals 90 kilograms. Okay, so that's the first answer. So we need to give 1 milligram per kilogram. So how many mLs are we going to give then? Remember, we've got 110 and we want to give 90. So how many mLs are we going to give? What's 100 divided by 10?
10.
Okay, so that means that there are 10 milligrams per ml. And I have 90 kilograms and I want to give 1 per ml. Or 1 per kilogram. So how many milliliters do I need to give to equal 90?
Should be 9.
Yeah. So 90 divided by 10 equals 9 mLs. Okay. How many milligrams are contained in the amount of fluid given? If I give 9 mLs, how many milligrams is that?
90.
Yeah. Pretty basic stuff, pretty easy. Nothing too crazy. All right, room 3 had question number 5. Room 3, who was in room 3? Without me having to look them up. Blake, Cassandra, Ethan, Dakota, and Jesse. All right, do you guys have an answer to yours?
We do, we think.
Okay. What you got?
You want me to go through the whole thing or just the answer?
Tell me what your answer is first.
We got 30 drops per minute.
Okay. Tell me how you got that.
So our weight in kilograms is 80.
Okay, so we have 100. Let me just draw this out too. We have a 176 pound patient. To turn that to kilograms, divide by 2.2 equals 80. Okay.
And then we took that times our 60 drop set.
So 80 times 60.
Yep, which is 4,800.
Okay.
And we took that times our 5 micrograms.
Times 4,800.
Yep.
Okay.
And then we divided that by 800 because we have a 500 milliliter bag.
Okay, I'm lost.
So we did weight in kilograms times our drip set times our dose divided by our med, which is
Is that a way Liam taught you guys?
I don't remember. I've had like 10 different people teach me 10 different ways. So
Let me kind of break this down because I'm kind of confused as well. Can I show you
And
my
we-
way?
Yeah, we also did the clock too. So
It came out at 30.
yeah, somebody confirmed with the clock.
Okay, so how I have that is they want you to give 5 micrograms per kilogram per minute, right? There's 80 kilograms we know, and we want to give 5 per kilogram. So 80 times 5 is what?
400.
Okay, so that's 400 micrograms per minute. Okay.
Mhm.
So I know that dopamine is a 500 ml bag. Dopamine is always supplied. Let's see, it's 400 milligrams in 500 mLs, but I'm ordering in micrograms, so that's 400,000.
And that's how we got our 800.
Okay. Perfect. It's and you're not wrong there. So that means 800 micrograms per ml, right? Okay. So let's put that in our clock here. 800 is the concentration, so 800 is going to go at the top. We're using a 60 drop set, so 60 would go there. And then half of 800 would be 400. That gives you 30. 15 would be 200. 645. You got 30 drops?
Yep.
Okay.
And we also attempted to use the weight in pounds, cross off the last number -2.
Mm-hmm.
Is that only for 1,000 milliliter bag?
That'd be 15, wouldn't it?
Yeah, we did that, and it was 15.
And I got 15 when I was doing it, and I'm not sure how I did that. But yeah, I did the exact method you were talking about. But
Mhm.
you're right. Yeah, I mean, you guys are right. It is 30 drops
Okay.
when you put it in the clock.
Mhm.
So yeah, your answer would be 30 GTTS per minute. Good job. You caught me because I had 15. So kudos to you guys.
Good. Thanks.
And by the way, I am recording all this. If we need to go back and if you guys need to go back in time and watch this for any reason, please do. All right, group 4 has by far the easiest question on this whole thing. Who was in group 4?
I was.
Okay. Yeah, I got Matt, McLean, Joel, John, Carrie, and Natalie. What'd you get for an answer?
5 mLs.
Okay, so let's look at that. So atropine is what they're talking about for a med. They want you to give 0.5 milligrams. It comes in a package, 1 milligram and 10 mLs. So if we put that into our formula, desired dose 0.5 over available dose 10 times available volume 10. So 0.5 divided by 10 is 0.05 times 10 is 0.5 milligrams. And if we have 0.5 milligrams, we just cut that in half. So instead of 1, This now becomes 0.5. So then what's half of 10? 5 mLs. Or you could just do the easy way and say, okay, if there's 1 in 10 and I want to give 0.5, obviously it's half. Does any of that make sense? If you're lost, at least you got, please tell me you got something out of this. Or if we need to go through something of a different sort or whatever it might be, now that I've got this whiteboard I can put up. All right, so here's what I want you guys to do. The biggest issues that I was seeing with you guys going over tests and everything like that was pharmacology and drug calcs. That's why I use tonight for what it is. On those extra credit forms, you guys just did handout 14. So fill in the answers, or you know what, actually we all did it as a group. I'll give each of you 2 points added to your grade for that worksheet alone. Now, there's 2 other worksheets. There's a handout for chapter 13 and a handout for chapter 15 on D2L uploaded, okay? If you get those done, I will give you an additional 2 points per sheet. So that could be a total of 6 points added to your grade. 6 points can make a difference between having a C+ and a B-. So for what it's worth, I would consider doing that. Is it mandatory? No. But to help your grade out, you can do those and email them to me, and I will add 6 points to your grade. As far as midterm, again, next week, you guys are actually going to do the midterm on Tuesday during class time. We're not going to hold a lecture or anything like that. The midterm will only be open from 6 to 10 Tuesday night. So you have to take that. We're not going to meet or anything like that. I'm not going to watch you take it because it is open book, so I don't really have to watch you do anything. Use that time to get your midterm done. There will be no, hey, I forgot to take my midterm or any of that. You'll get a 0 for it. Make sure, I know that my Brady, that's my homework for you guys whenever I assign my Brady. And I know I gave you guys a lot of exams in the first part of this, first part of the term. And I'm sorry for that, but we covered a lot of important chapters such as airway, med calcs. The next, little bit of time, we only have one exam besides our midterm and our final, and that's just for chapter 12. So your final, again, will be comprised of a lot of the same questions at the end of the semester that are in your midterm and were in all of your exams. If you guys have any trouble with anything, I'm going to try to send out those surveys as frequently as I can to you guys, just so I can kind of get a basis of where you guys are at in school. I had a little pep talk with the day class today, and I informed them that, I've been teaching at Mercy for 7 years total, and every single class that comes through in the first semester, everybody kind of freaks out. You're thrown so much information in such a short period of time, and you just feel lost. You feel like you're not grasping anything. I hate to say that's kind of normal because we're throwing a ton of information at you and wanting you to retain it. You aren't going to know the why of anything at this point. And a lot of that won't come till second semester when we start digging into, the systems of the bodies individually, especially when we start dealing with the cardiac system. Cardiology is a massive, massive part of being a paramedic. And that's a lot to do with the medications that we give. I promise you guys, and I told the last class this and they thought I was insane. And now a lot of them have walked away as paramedics now. Give me 100% of yourself and I will give you 100% of me. I can be your best friend. I can be your worst enemy. I will do everything I can to help you guys pass, as long as you're doing everything you can to study and keep up. And I get it. There's gonna be times where you want to break down, and paramedic school is hard. It's not an easy task going to paramedic school. I get it 100%, but stick with it. And I promise I'll help answer any questions you have for you. I'll go to bat for you guys. I'll do whatever I can to make sure that at the end of this program, you guys take that national registry and are paramedics after that. I know it seems like a lot of information, it is, but this is how the program works. It's the same way when I went through Mercy's paramedic program. It was the same program, different instructors. I just ask that you give us a chance to, show you a lot of this stuff and try to, pound it into your head into second semester a little bit more. Again, a lot of first semester is, hey, I want you to remember minute bits of this information. I can tell you from the last class, none of them probably remember anything in first semester, but they remember everything of the skills we did in first semester. Second semester is when they started putting all the knowledge together along with the medications that we were asking them to study. Do you guys have any questions for me or anything?
The drug cards are due Tuesday, right?
Yeah, and so just I don't know. Send me if you're you're in, I can't remember, are you in the Mesa City class or no?
No.
Okay. Yes. We'll just say next week sometime. I won't be there Thursday night next week. It seems like I'm missing every week. But what I want you guys to do is take a picture of them and just email it to me so that way I know you've got them done. And it doesn't have to be all of them. Just send me, 10 of your drug cards. And I just so I can see the layout of everything. And we will make sure that you get the points for it, okay? Any other questions? Has everybody finished their exam? The last one that we had? Because it's due tonight at midnight. If you haven't, I would go get that done. Other than that, guys, have a good night. If you have any questions, email me. And I'll help you out where I can. Have a good night, guys.
Thank you. Have a good night.
Thanks.